So then they might need to do the hysterosalpingography. Okay, it is done. Now I will talk about the saline sonohysterography. In salpingohistogram, they insert the contrast dye and they take the X-ray. But in saline sonohysterography, they insert the saline water, then they do the ultrasonography. No radiation, no X-ray. Okay, let's talk about that. Saline sonohysterography. That means they use saline water, 25 ml of saline water. Okay, they inject this into the uterine cavity through the tube, but they have to dilate the cervical canal first, then they will insert the tube and they will inject the 25 cc of saline water. How do I know that water is going to the uterus? Because they do it with the help of ultrasonography. It is known as ultrasound guided saline sonohysterography. Now question, why? Why a patient need it? Why? Why a patient need this saline sonohysterography? Very important question, and the answer is very nicely given. Okay, so now question that what is the indication of this? Okay, let me write down the indication, then I will discuss the steps. Number one, thickening of endometrium. Then endometrial polyp. Submucosal and pedunculated submucosal fibroid. Endometrial neoplasm. Mostly it is if it is a cancer. Okay, then history of taking tamoxifen. then estrogen for the osteoporosis after menopause. Some women may need estrogen. Okay, there might be menorrhagia. Menorrhagia, too much bleeding. Okay, so these are the indication of the saline sonohysterography. So in this examination, they like to see, is that endometrial thickening, which is unusually greater 1.5 centimeter, is due to a growth, endometrial cancer, or due to a polyp, or simply thickening of the endometrium, or there is a pedunculated fibroid. Then how can we rule out? Keep that in mind. The endometrial cancer is attached with the wall, widely attached, with a hypervascularity, irregular margin. I like to see that. How are we going to see? Oh, that's why I am injecting the water inside the uterine cavity, making it wider. It will also giving us the anechoic area. So anything against the background of anechoic, everything is clear. I will see this. If it is an endometrial polyp, then mostly it is a pedunculated polyp. And pedunculated polyp has one end attached with the uterine wall, and another end is free inside the uterine cavity, and the anechoicness will be all over except the polyp area. I will draw each and every diagram. And if there is a simply endometrial thickening due to tamoxifen or estrogen, so there will be no polyp, no mass, and it's clearly seen. If there is a uterine synechia, the uterine anterior wall to posterior wall are fused, or two lateral walls are fused, then you can see that synechia addition. You can see this. If there is a foreign body inside the uterus, you can see this, because the saline water will make the background dark. So you can see this. Now let me give you the story. So in saline sonohysterogram, there is an ultrasound guidance. So sonographers will be there. The doctor will be there, who will actually insert the catheter or the tube or metallic rod first, or plastic tubes through the cervical canal, making it dilated, and finally they insert the catheter that goes inside the uterine cavity, and they inject the 25 cc of water and sonographer water into the uterine cavity. And sonographer, your job is to show that water is going into the uterine cavity, and make sure you have to, the doctor, they have to avoid the air bubbles while they are inserting the water into the uterine cavity, because air bubble will give the snow storm or dirty shadow. It might obscure the underlying tissue. Okay, and usually the doctor will remove the air bubbles, then they will insert. Okay, and ultrasound can easily identify what is going on. Okay, so then all those are supposed to be in a sterile condition, and when the evaluation is done, and our sonographer will take the picture, image, and at that spot, yeah, they will find out, yes, we find something, and now we know who is what. Who is this inside the uterus bothering this woman? But they will not do the next thing, that is the taking off if there is a polyp and sent for biopsy. No, they will do it in different settings. This is one setting, that is saline sonohysterography. Okay, so now I will discuss with the diagram. You got the indication. Okay, let's do okay, let me make it little wider so that it will be easy for me. Okay, as you know, this is the external os and this is internal os, and this is cervical canal. This is external os. This is internal os. And this is vagina. Okay, this cervical canal is tight, and the external os, internal os is also tight. It needs to be dilated. That's why they will insert the tubes through the os and the cervical canal, and in order to make it wider. In order to make it wider. Then with the tube they will insert the water, saline water. Okay, so 25 cc saline water is injected by a syringe and the water is coming inside. Keep that in mind. At the beginning, this is the thickness, like AP measurement is 2.5 centimeter, which is much bigger. Normally it is 1 centimeter, it can go 1.2, 1.3, 1.4. I found 1.5, but it's still is fine, no problem. Okay, so that okay. I'm drawing the endometrial tissue. I always prefer to draw with that red because the red is highly vascular area. Okay, this is endometrial, but you don't know, is it simply hyperplasia or there is a polyp, or there is a mass, malignant mass inside, it looks homogeneous when there's a polyp. When there's a hyperplasia, it looks homogeneous, medium to little higher echogenicity. Okay, so then how can you differentiate who is this? Okay, so now understand that there might be a polyp. Okay, there might be a polyp inside the uterine cavity. Okay, let me draw that polyp for you. It's a huge big polyp. Okay, there's a big polyp over here, and it gives the homogeneous appearance, and its echogenicity match with the endometrium. Okay, so this is polyp, and this is endometrium. But how can I know this is the polyp? Okay, how can I know this is not the endometrial hyperplasia? How can I know it is not a growth from the endometrium? Now, let's send the water. Okay, now they are injecting the water. And I said to you, water is anechoic. So water will go around the polyp, and it will fill rest of the space in the uterine cavity. Okay, so now you can see these are the water, and this is separated from the endometrial tissue. Then you can see this is a polyp. This is a polyp, and this polyp is attached by a pedicle. Is attached with a pedicle, and through that pedicle you need to click the color. Then you will see there is a blood vessels. Okay, you will see there is a blood vessels. and it is found at the pedicle, the artery and the vein. Okay, it is confirming that this is the feeding artery and vein supplying the blood to the polyp. Okay, and it is a narrow pedicle, wide body and fundus. Okay, so this is polyp. If it is a simply hyperplasia of the endometrium, so then water will be in the center and the endometrial tissue will be around it. The water is anechoic, endometrial tissue is the mild hyperechoic. If it is a cancer, how it going to grow inside the uterine? Okay, so now I will show you how it going to look like with the saline sonohistogram. Let me show you here. Okay, you will see when the fluid will go inside, fluid will give the anechoic area inside the uterine cavity except the area where the mass is. Okay, now you can see this is the mass. Okay, put the different different shades. Okay, so now you can easily see it's a different looking, and you click the color, then you will see the blood vessels. You will see the hypervascularity. Okay, and the broad base, not like a pedicle. So this is neoplasm, and mostly it is cancer, and this is your saline water. Okay, so that's the way And definitely that's the way we can differentiate. And don't forget the same procedures of giving the water. Okay, I hope you understood the importance of the saline sonohysterography. It can rule out the polyp, it can rule out the adhesion, it can rule out the endometrial hyperplasia, it can rule out the neoplasm inside the uterus, and it can rule out the adhesion, and it can also rule out the hormone induced hyperplasia. Okay, so it is very important, and when it is diagnosed that something is wrong, so then they will do the next step in the next setting, but not this setting. Okay, usually they will do the biopsy. If there's a polyp, they will take off the polyp. Okay, and keep that in mind, this kind of polyp may be inside the cervix. In the cervical canal there might be a cervical polyp. But that polyp, usually they don't do the saline sonohysterography, they will do the ultrasonography, and they will take the polyp out. They will try as much as they can remove the polyp, because that polyp can obstruct the menstrual flow. That polyp in the cervical canal can cause the infertility. Okay, so this is important, you have to remember. So now saline sonohysterography is done. Now I will talk about the CT and MRI. Okay, CT, just we don't do CT, we don't do MRI, but just for your information, just know that CT is a radiation, and CT is not good because the too much radiation can be absorbed in the body. Okay, and young girl should be avoided with the CT. They should be given the ultrasound. And if it is indicated that MRI should be done because there might be cancer and the stage 2, 3, 4, 5, we need to see the extent of spread of the neoplasm, then do MRI. And you know that MRI is a radiomagnetic wave, not radiation, and MRI is expensive. You have to wait for approval too. The CT, you need an approval, but you can do quickly and not that expensive as MRI. The good thing is that you can compare the CT with the ultrasound findings and the MRI with ultrasound findings. If you see that result of CT and MRI is in the patient's file, patient chart, you can compare your findings. You can read and understand what is the patient's diagnosis with, and am I getting the correct things or not.